Good evening, good morning, good afternoon to everybody who is joining us from whichever part of the world you're joining us from. सबैजनालाई आज स्वागत छ. We are very happy to have you here with us in the third webinar. हाम्रो यो नेपाल मेन्टल हेल्थ रिसर्च सिरिजको थर्ड वेबिनारमा तपाईहरु हामीसँग यहाँ हुनुहुन्छ. मेरो नाम कृतिका सिंह हो अनि म जर्ज वाशिंटन युनिभर्सिटीसँग नेपालमा मेन्टल हेल्थ रिसर्चको लागि रिमोट कन्सल्टेन्टको रूपमा काम गर्दैछु र आज मैले यो वेबिनारलाई मोडरेट गर्दैछु. तपाईहरु सबैजनाले यो स्क्रिनमा देख्न सक्नुहुन्छ. आजको हाम्रो वेबिनार इज अन स्टडीइङ सुसाइड प्रिभेन्सन, प्रोफेसनल एन्ड पर्सनल वेलबीइङ फर रिसर्चर्स. As we all know, September 10th is the World Suicide Prevention Day. अनि त्यसले गर्दाखेरि चाहिँ we're attempting to focus a little bit on practitioners and researchers working with suicide prevention today. So आजको हाम्रो यो 1 घण्टाको वेबिनारको फोकस यसमै रहन्छ. Our speakers today are Dr. Ashley Hagaman and Kripa Sigdel. दृष्टि गुरुङ जो चाहिँ टिपिओ नेपालबाट हुनुहुन्छ र हाम्रो रिशेप प्रोजेक्टको प्रोजेक्ट म्यानेजर हुनुहुन्छ. उहाँले केही समयमा हाम्रो स्पिकर्सहरुलाई इन्ट्रोड्युस गराउनुहुनेछ र हामीलाई यो वेबिनार भित्र लिड गर्नुहुन्छ उहाँले. तर जस्ट अ कपल अफ सुपर क्विक हाउसकीपिङ आइटम्स बिफोर दैट. यो हाम्रो लोजिस्टिक्स वेबिनारको जुन हामीले फलो गर्नुपर्ने हुन्छ. I want to let everybody know कि हाम्रो यो वेबिनार is being recorded today. यो वेबिनार रेकर्ड भइरहेको छ. तपाईहरुले एउटा सानो पपअप देख्नु भयो होला. त्यसलाई प्लिज एक्सेप्ट यस गरिदिनु होला. We will be sharing your webinar for recording, your presentation for slides, as well as all the webinar materials with you after the webinar. हामीले इमेल को मार्फत तपाईहरु सबैजनासँग यो शेयर गर्ने नै छौं. यो सबैलाई पब्लिकली अवेलेबल हुन्छ त्यसपछि. अनि to talk about the way the webinar is going to be, we have 30 minutes for both our speakers, and after our speakers' presentation, we will be having 20-25 minutes for discussion, जुन चाहिँ हामी एकदमै encourage गर्छौं. Throughout the presentation, यदि तपाईलाई केही questions छ भने तपाईले हाम्रो chat box मा हाल्न सक्नुहुन्छ. The chat feature is enabled and you can put in your questions there throughout the webinar. अनि at the same time हामी यो डिस्कसन को बेलामा यो सबै बारे कुरा गर्ने छौं. अनि यदि तपाईहरुलाई डिस्कसन पछि ह्यान्ड रेज गरेर पर्सनली क्वेशन्सहरु सोध्न चाहनुहुन्छ भने we can also do that after once we open the floor for discussion. One more thing from me. Towards the last 15 minutes of this webinar, हामीले एउटा feedback form तयार पारेको छौं जुन चाहिँ हामीले chat मा हाल्छौं. We have a feedback form that we will put up on chat. हामी सबैलाई एकदम encourage गर्न चाहन्छौं कि please feedback form चाहिँ भर्नु होला, because हामीले as we know this is a series of webinars अनि तपाईको feedback ले हामीलाई हाम्रो next webinars like iteratively better बनाउनलाई एकदमै help गर्छ. अनि अर्को reason भनेको चाहिँ we're also planning to give out certificate of participation हाम्रो वेबिनारमा आउनुहुने साथीभाइहरुलाई. अनि त्यसको लागि पनि we will be in touch with you regarding the details of the certificates. तर please do make sure that you fill in the feedback forms, which is very important for the certification process. One last thing from me is on future events. हाम्रो यो webinar is a monthly webinar which is on the 3rd week of every month. तर हाम्रो next webinar is going to be in November. We don't have a webinar in October किन भन्दाखेरि दशैंसँग overlap हुन्छ हाम्रो webinar को time. We will obviously keep you updated as we have been doing until now by means of email and त्यसपछि other forms of notification. हामी तपाईहरुलाई डिटेल्सहरु पठाउँदै नै गर्छौं. If you have not followed us until now, please follow us on Facebook and Twitter. These are very good ways to stay in touch about our future events. And at the same time, if you have any questions, feel free to write to us. Your slide will also be shared with you, so you can have this information after this webinar. So with this, that is all from me. Over to you, Drishti.
Thank you so much for that briefing, Ritika. Hi, everyone. Good afternoon, good evening, good morning, wherever you are. It is my great pleasure to introduce to you our speakers for today, Dr. Ashley Hagaman and Kripa Sigdel, for this month's webinar series titled Studying Suicide Prevention, Professional and Personal Wellbeing for Researchers. As Ritika mentioned earlier, the topic itself is very relevant for this month's webinar series because we all know that September 10th is celebrated as World Suicide Prevention Day, and there are various suicide prevention activities carried out throughout the month of September. As the cases of suicide is on rise each year in Nepal, we wanted to delve deeper into evidence surrounding suicide prevention in Nepal and what ethical and practical issues arise for researchers, especially for early career researchers who want to conduct research on topics related to suicide in Nepal. Addressing these issues, we have with us first Dr. Ashley Hagaman, who is an assistant professor of public health in the Department of Social and Behavioral Sciences at Yale School of Public Health. She is also a qualitative methodologist with the Center for Methods in Implementation and Prevention Sciences and holds a secondary appointment in the Department of Anthropology. Her research examines the complex collection of factors that influence depression and suicide in varying cultural contexts, particularly among vulnerable populations. I think you can view her detailed bio, which Ritika, please do post in the chat box. Second, we have also with us Kripa Sigdel. Kripa is an academician and mental health counselor by profession. Her expertise and interests lie in academia, suicide prevention, relationship counseling, and psychosocial training facilitation. Additionally, she is a part-time faculty at Padmakanya Multiple Campus TU and pursuing her PhD in psychology from Central Department of Psychology TU, focusing on counseling and mental health. Currently, she is working as the research coordinator for a research project conducted in Nepal by Yale University. Now, I believe this is in collaboration with Dr. Hagaman on integrating suicide prevention practices into health systems. And so their presentation and discussion today stems from their experiences of their work on this project and their past projects. So without taking any more of your time, I turn it over to Dr. Hagaman and Kripa Sigdel. Thank you both.
Okay, thank you. Let me just make this in the presentation mode. So namaste, मलाई एकदम खुसी लाग्यो तपाईहरुसँग कुरा गर्दा तर मेरो नेपाली एकदम राम्रो छैन त्यसको कारण म अंग्रेजीमा बोल्छु ठीक छ So I'll speak in English. I'm just going to go ahead and get started. So today I'll give a brief overview of the suicide burden globally, a really short overview of some of the suicide prevention projects that we have ongoing in Nepal. And I really want to focus a lot on some of the challenges that I've been thinking through alongside my teams related to ethics in doing research on suicide and mental health in general. And then Kripa is going to talk about how she bridges community mental health practice and research, resources for suicide prevention that we incorporate both in our team's sort of well-being, but then also in our research projects, and the challenges of being an early career researcher. And so, you know, we look forward to the conversation and welcome your ideas, questions, and experiences. So I know I've learned a lot from following the trajectories of other scholars, and I got the sense that this might be of interest to folks, just given the audience. And so I wanted to share some of my own background with you. So I finished my bachelor's many years ago, and then went into the workforce for several years where I built a small global health nonprofit called GlobeMed alongside some other really incredible movement makers. And I had the opportunity to travel around the world and learn from community-based health organizations. And I was deeply inspired by one woman in particular that was leading psychosocial well-being programs in northern Uganda in a war-affected area. And so that's why I wanted to support the growth of public mental health work around the world. And I went to Emory for my master's in public health. And actually the reason I went there, as many folks on this call probably know, Dr. Brandon Court, and I went there because he was on faculty there at the time. And so I worked with him and collaborated on an interdisciplinary project in Haiti, where we epidemiologically examined the burden of depression and anxiety. And there I learned first that I loved field work. I loved how much I learned every day, how uncomfortable I was, like uncomfortable, discomfort, and how much I really grew, I think, as a human. You know, our team there uncovered a lot of individuals that were endorsing suicide ideation in our quantitative study. So I then went to the literature to see what other research was done on suicide in Haiti, and there was nothing. In the Caribbean, nothing. In low-income countries, very, very, very little. So there was a huge gap, and we really didn't understand a lot. And so I did a qualitative investigation then in the field to talk to people that were experiencing suicidal thoughts, talk to healthcare workers about how they negotiated patients that were endorsing suicidal thoughts, and learned a lot. And that's when I decided that I wanted to go do my doctorate in medical anthropology to really use these qualitative research methods to gain really important stories about this burden of suicide in contexts where we really know very little. And so Dr. Brandon invited me to explore suicide in Nepal, given recent reports about you know, high burdens of suicide, particularly among women. And so I got a Fulbright scholarship, and I moved and lived in Kathmandu and took really like intensive language classes, which, you know, perhaps have now worn off. But I lived in Nepal for almost 2 years and did my dissertation research. And importantly, I wanted to share that my doctoral chair of my dissertation committee was a really amazing female scholar named Dr. Amber Wooditch, and she's a powerhouse. And it was really important for me to be mentored and trained by another woman in academia that had a family, that had kids, and I learned so much from her and her experience. And so really, after focusing on uncovering the ethnographic nature of suicide and just sort of documenting the problem, I wanted to more training in intervention design and evaluation, because I wanted to be able to do something about it. And so that's when I did my postdoctoral fellowship at UNC in intervention evaluation and studied more maternal and child health, where I focused a lot on maternal mental health. So now I'm at Yale School of Public Health as an assistant professor, and here I lead a lot of our qualitative methods training. And so Drizzy talked a little bit about that, and you know, I'd be thrilled to talk more, but I hope that's just that summary is useful to understand kind of where my trajectory came from. I'll spend a tiny bit of time talking about the global burden of suicide around the world. It's, you know, almost 800,000 deaths every year. But deaths are really only a fraction of the problem, where there are up to 20 million individuals that attempt suicide. And so the effects that has both on that individual and their family, you can see is enormous. It's a public health problem that is seemingly intractable, and we are not good at having effective prevention programs where we have reduced the burden of suicide. And so over the past several decades, suicides have increased. In Nepal in particular, and I'm sure a lot of folks on this call know that in 2012, it was ranked the 7th highest rate in the world. But recent reports, when they sort of reconfigured their modeling strategies, because Nepal doesn't have systematic reporting of suicide deaths, it all has to be modeled, and now they're ranked 72nd. So my first, you know, we need to be very careful about how we interpret those, but I think the larger point is that there's just not robust data for us to really have a sense of inference. Regardless, it's a problem, so that's why I have this police data here, that you can see the number of cases that police are reporting in Nepal. That red line is the percentage increase over time. It's certainly increasing based on police reports. And then, of course, as everyone knows, it's not surprising that 75% of suicide deaths happen in low and middle income countries, and that's because most of our world's population is in those countries. But regardless, the research doesn't focus on the burden in those areas. So it's wildly skewed towards Western contexts. It's worth noting that some of the more effective strategies that we have to prevent suicide are means restriction. And in low income settings, pesticides are the most common means. And so that really directs a lot of the suicide prevention efforts that are happening in these settings. And so our research that I work with our teams and my lab at Yale, and collaborators around the world, is really dedicated to working alongside health systems and their communities to address the gaps in suicide research and improve access to care. And so suicide is a rare and complex event. There's not one single thing that drives it. And so it requires a range of innovative approaches to study and develop evidence base about what works. So I'm not going to spend a lot of time on this slide, but I wanted to point out that there has been a good amount of research on suicide in Nepal. I mean, not a ton, but there are some unique features that I think are worth noting. Attempts are certainly disproportionately, as with other regions of the world, there are more male deaths in Nepal than female deaths. There's been sort of a historic focus on females because of some reports. But, I think some of the interesting, so young women in particular and young folks in particular, and Kripa will talk a little bit about this, but some other features that I think are interesting is that in some of our formative work, we found that geographic relocation has been tied to increased suicidality. So things like moving for migrant labor or moving because of new marriage into the husband's home. And so some of these geographic shifts and important life events also create contexts where it might increase someone's suicidality. And then, of course, as everyone knows, there's a lot of stigma around disclosure. But some of the work that we've done with doctors, and actually this is unpublished, and we should probably get around to publishing this with some of our data, but there's a lot of tension that doctors feel because of just the limitations that they have with how suicide is documented and reported from the police. And so those legal policies actually create some tension for them to engage in sort of building the data and creating robust systems for data reporting. And then I also wanted to mention that the WHO very recently released this report called Live Life that sort of makes recommendations for implementation priorities for suicide prevention work. And so our work really focuses on this fourth point here, which is the early identification, assessment, management, and follow-up of anyone who's affected by suicidal behaviors. So that's both someone who has engaged or thought about suicide and their families and their social networks. And then I also wanted to point out that the International Association for Suicide Prevention just launched, like Kripa and I were just on a call a couple weeks ago, a regional suicide prevention network program that is including Nepal. And so if anyone on the call or knows anyone that's interested in contributing to this network, we would be very happy to involve you and talk with you. So I briefly will talk about one of our suicide prevention projects that we are launching in Julikel. And this is to integrate a suicide prevention package into task-shifted mental health interventions in general. So we are doing this at Julikel Hospital alongside Kathmandu University. And this project is co-designing a package of brief evidence-based interventions, suicide prevention strategies to help Julikel Hospital staff better detect and respond to suicide. So this is the amazing team that I wish I could talk about forever because they are incredible, but we are collaborating with emergency department staff and the psychiatric department staff and Lakshmi Vijayakumar, who is a wonderful mentor to the project, who's a suicidologist in South India. And so the goals of the project are quite simple. Oops. No. First, to do a qualitative exploration of health system readiness for suicide prevention, to co-design that package of practices alongside hospital staff, alongside stakeholders, and alongside people with lived experience of suicide. And then pilot test the feasibility and acceptability of that package. And so why brief interventions? Well, because most patients don't follow up from mental health services after going to the emergency department for a suicide attempt, that a lot of screening doesn't happen. And so if we can implement universal screening in an emergency department, we can actually detect a lot more suicidality and prevent it. And we know suicide risk is highest in the 3 months after discharge from the hospital. People are discharged with a lack of support network. We know that's a part of what contributes to their suicidality. And these brief interventions in particular don't require specialists for delivery and are very short and cost effective and just have evidence base that they really do prevent suicide. So what does this mean for our project? We're exploring universal screening in the emergency department, safety planning for anyone that is detected at risk for suicide, and doing some brief contact follow-up. So these caring contacts have been shown to be really effective. So it's just simple brief phone calls. They're not therapeutic. They're simply checking in and helping someone connect to services that they need. So lastly, I wanted to talk about some of the ethical challenges that I've really been thinking through, and to note that I am an American woman that is doing work in settings that I am not from. And that certainly for myself creates a lot of challenges. I think it's very exciting, and I get to work alongside really amazing people like Kripa and have the opportunity to do that. But also there's a lot of gaps, right, in my own lived experience with the populations that I'm studying. But so for suicide prevention research in particular, I really think about, from the participant's perspective, what does consent mean? If they don't consent, what do we do? There are tensions with family involvement. So we know often that family conflict is perpetuating or exacerbating suicidality. And so really thinking through, because family members closely accompany participants to in the healthcare setting, there's a really careful dynamic to ensure confidentiality, but also involve the family in the intervention itself. And so we also know that family members have increased risk for suicide if someone in their family is suicidal. And so we need to be prepared for that and be prepared to respond to that. So if they're not a participant of ours, how do we engage them, or how do we respond to them? So there's a lot of training and resources that are needed to ensure participant safety. And so this frankly should be done with any research. I don't think it should only be done with mental health research. I think for any research, there should be these safety protocols assessing participant distress, not just suicidality, but having very robust and practiced and enacted referral chains and resources to transport participants to care if they need it. We're also implementing some safety cards if someone is in distress, again, not only suicidal, but just to work with them to identify their coping strategies and to just help them if they are in distress. So there's a lot of wraparound services that are necessary for when researching something like suicide, but frankly, I just think it should be in any research project. So I also think a lot about our research teams, and we just submitted an opinion piece to the WHO Bulletin about how to ensure mental well-being for our staff. So we train all staff, no matter what their role is. They could be biostatisticians, they could just be data entry folks, or they, US-based, field-based. Everyone gets trained in psychosocial first aid. Kripa is actually leading one of our trainings on Friday, and trauma-informed research. And we have regular team debriefs and group supervision to support things that come up in the field, address, potential traumas from exposure to really difficult situations. And then I'm providing paid group mental health sessions that Mankakura, which is actually a telehealth delivered therapy organization in Nepal, as well as one-on-one individual counseling for every single one of my staff members. So that comes out of our research team budget, and I budget for that. It's also important that my team has paid mental health days, and that I create a culture and demonstrate from leadership that, to affirm and validate the need for things that make us feel happy and fulfilled outside of our work, and that we need rest. and time for space for that. So those are some things that I do with my research team. I'd be curious, to hear what others think about it. And if there are other ideas, I'm always sort of searching for ways to ensure that, particularly when we're asking our researchers to learn about really traumatic experiences from participants that are probably really hard to hear. And I know Seema Khadka is on this call, and we've worked together in the past, and Seema has really taught me a lot about how to support a research team member. And so finally, I'm really thinking about how to disseminate and involve communities in our work in meaningful ways. And so of course we have community advisory boards, but they can be quite performative. And I think it's, we need to be very intentional about how we use their time. And I've struggled, in particular to integrate our whole team in publishing. And so given that there's almost never any protected time for Nepal-based or field-based staff to really lead their own analyses or lead writing, I need to think about how do we create time and space for that? How do we sort of allow for that in our research teams to make sure that everyone has the opportunity to lead and co-author manuscripts? And so, also just thinking about how to best disseminate our research in ways that are easily consumable for our study communities. And so we're planning more infographic displays for our findings, engaging social media and press more. So I'm going to stop here, and I look forward to the conversation and feedback, and I'm going to hand it over to Kripa for the next part.
Thank you so much, Ashley. Namaskar, Sabajana. Thank you so much, Ashley, for making space for my presentation. While preparing for this presentation, we have decided we'll switch the language to Nepali in the second half, that is on my presentation. So I'll be mixing both Nepali and English, mostly Nepali, while presenting. So let me share my screen. Ashley, I think you should तपाईले बन्द गर्नुपर्छ so that I can share. So thank you so much. सबैजनालाई फेरि पनि नमस्कार. So मेरो आजको पार्टमा मेरो सेकेन्ड हाफमा चाहिँ मैले अर्ली करियर रिसर्चर र अर्ली करियर प्र्याक्टिसनरलाई जोड्दै सो के इश्यूज हुन सक्छ, त्यो च्यालेन्जेस के हुन सक्छ र त्यसलाई कसरी इन्हान्स गर्ने, आफ्नो वेलबिङ पर्सनल र प्रोफेसनल वेलबिङलाई कसरी इन्हान्स गर्ने भन्ने पाटोमा बढी कुरा गर्छु. So this is me, smiley face, and then म 2017 देखि 2017 देखि चाहिँ म मेन्टल हेल्थ काउन्सिलर र एकाडेमिशियन भएर नेपालमा काम गरिरहेको छु. मैले प्रोग्राम डेभलपमेन्ट रिलेटेड टु मेन्टल हेल्थमा पनि इन्गेज छु साइक विज्ञान नेटवर्क नेपालबाट 2014 देखि. मैले नन क्लिनिकल केसेस बढी हेर्छु मेरो कामको दौरानमा, मेरो प्र्याक्टिसमा, मोस्टली एडोलेसेन्ट्स र युथ, र सँगसँगै चाहिँ टिमसँग साइकियाट्रिस्ट र प्रोफेसनल अरू साइकोलोजिस्टको टिमसँग चाहिँ क्लिनिकल केसेस अनि सिभियर सुइसाइडल आइडिएसन भएको केसेस पनि हेर्छु. सो यो चाहिँ मेरो प्र्याक्टिस मेन्टल हेल्थ प्र्याक्टिसनरको जर्नी भयो भने रिसेन्टली मैले डाक्टर हागमनसँग यो रिसर्च प्रोजेक्टमा कोलाबोरेट गरेर काम गर्दैछु लास्ट 3 महिनादेखि. र सँगसँगै चाहिँ मैले अहिलेसम्मको मेरो रिसर्च जर्नी भनेको चाहिँ मैले पोलिसिज रिभ्युज, युथ मेन्टल हेल्थ अनि वर्क प्लेस मेन्टल हेल्थ अनि एजिङ पपुलेसनको गरिरहेको छु. सो त्यो चाहिँ भयो मेरो बारेमा. सो अब अगाडि बढ्दाखेरि मैले अघि भने जस्तै मैले मेरो प्र्याक्टिस र मैले रिसर्चलाई चाहिँ जोडेर आजको प्रेजेन्टेसन तयार पार्न खोजेको छु र हामीले खोजेका छौँ. सो लेट मी स्टार्ट विथ एउटा केस. 2075 सालको घटस्थापनामा एकजनाले फोन गर्नुहुन्छ र भन्नुहुन्छ, कृपा दिदी म बाँच्न सक्दिनँ, आई जस्ट डु नट वान्ट टु लिभ, आई डोन्ट नो कसलाई गर्ने, म एकदम एक्सट्रिमली ओभरवेल्म भइसकेँ, म थाकिसकेँ, आई जस्ट वान्ट टु गिभ अप, मलाई कसैले पनि विश्वास गर्दैन. सो मैले के गरेँ, मैले सिम्पली सुनिदिएँ मात्र. केही स्किल्स पढेको थिएँ, केही स्किल्समा इन्ट्रेस्ट थियो, सो त्यसले गर्दाखेरि मैले एक्टिभ लिसनिङ स्किल चाहिँ त्यो बेलामा युज गरेँ. मैले सेफ स्पेस क्रिएट गर्दै 1 घन्टासम्म हाम्रो कुराकानी भयो सेफ स्पेसमा आउनलाई, र सँगसँगै उहाँको एक्सप्रेसनलाई चाहिँ एउटा सेफ स्पेस दिनलाई ट्राई गरेँ. त्यसपछि गएर मैले चाहिँ उहाँको फिलिङ्सलाई भ्यालिडेट गर्दै त्यसपछि नेक्स्ट स्टेप के हुनसक्छ त भनेर चाहिँ त्यसमा हाम्रो कुराकानी भयो. लाइकवाइज अर्को एउटा केस, एकजनाले फेसबुकमा लेख्नुहुन्छ, मेरो स्टुडेन्टै हुनुहुन्थ्यो, उहाँ 4 जनालाई मात्रै ट्याग गरेर 4 जनाले मात्रै देख्ने गरी लेख्नुहुन्छ, आई एम गोइङ, आई एम जस्ट लिभिङ, थ्याङ्क यू फर होल्डिङ अन टु मी टिल नाउ भनेर. एक्ज्याक्टली यही नै थियो. त्यसपछि गएर मलाई थाहा थियो उहाँ मेरो स्टुडेन्ट भएको कारणले केही सोर्ट अफ मेन्टल हेल्थ इस्यु छ भन्ने थाहा थियो, प्रोफेसनलका जानुपर्छ है भनेर पनि बुझाएको थियो, तर जानुभएको थिएन. इमिडिएटली त्यो फर्चुनेटली मैले विदिन फ्यु मिनट्स नै त्यो हेर्ने हुन्छ नि, आई वाज लकी इनफ कि त्यो फ्यु मिनट्समै हेर्न पाएँ. मैले डिरेक्टली उहाँलाई फोन गरेँ, स्विच अफ थियो, भाइबरमा नम्बर भएको कारणले नम्बर अभाइलेबल थियो, मेसेन्जरमा कल गरेँ, अनलाइन हुनुहुन्थेन, उहाँको साथीलाई फोन गरेँ, साथीको पनि रिच उहाँले साथीले पनि रिच आउट गर्न सक्नु भएन त्यसपछि गएर अब आई डिडन्ट ह्याभ एनी अदर अप्सन त्यसपछि गएर त्यसपछि डाइरेक्टली मैले के गरेँ भन्दा चाहिँ मैले 100 पुलिसलाई फोन गरेँ अनि एउटा सोशल मिडिया भइसकेपछि हामीले कहिले कहिले ट्याग गर्छौँ फर द्याट रिजन मलाई उहाँको बाबाको नाम चाहिँ थाहा थियो पुलिस ट्र्याक्ड उहाँको फादर त्यसपछि गएर उहाँको नम्बरलाई ट्र्याक गरेर चाहिँ विदिन 15 मिनट्स मलाई पुलिसबाट फोन आउँछ र भन्नुहुन्छ कि सी इज सेफ नाउ उहाँको पेरेन्ट्स उहाँको रुममा गएर सी वाज अबाउट टु हुन्छ नि डु इट त्यसपछि गएर उहाँ अहिले चाहिँ सी इज सेफ नाउ भनेर र अहिले मैले बुझ्दाखेरि चाहिँ सी इज टेकिङ साइकोथेरापी अनि त्यसपछि गएर फलोअपमा साइकेट्रिस्टसँग पनि फलोअपमा हुनुहुन्छ लाइकवाइज अर्को केस एउटा पर्सन साइन अप गर्नुहुन्छ हाम्रो साइक विज्ञानको काउन्सिलिङ सेसनको लागि उहाँ हामीसँग टाइम लिइसकेपछि चाहिँ सुइसाइडल थटको बारेमा सेयर गर्नुहुन्छ उहाँलाई सुइसाइडल थट कहाँबाट आइरहेको छ त एक्जिस्टेन्शियल एङ्स्ट करियरको त्यो ट्रान्जिसन फेजले गर्दाखेरि एक्सट्रिम स्याडनेस भइरहेको रहेछ त्यसपछि गएर उहाँसँग बुझिसकेपछि मैले के गरेँ सो मेरो प्रोफेसनल थेरापिटिक जे मैले गर्न सक्थेँ जुन मेरो प्र्याक्टिस त्यसले चाहिँ मैले उहाँलाई सपोर्ट गरेँ सँगसँगै हामीले एउटा टिममा रहेर इन्टरभ्युन गर्यो प्रोफेसनली सी इज अन्डर मेडिकेसन अहिले पनि उहाँ फलोअपमा पनि आउनुहुन्छ र रिएडजस्ट भइराख्नु भएको छ आफ्नो लाइफमा मैले यो किन सेयर गरिरहेको छु के मेरो केसेसमा एज अ प्र्याक्टिसनर के काम गर्यो त भन्दाखेरि एक्टिभ लिसनिङ सिम्पल स्किल त्यसपछि गएर भ्यालिडेसन अफ द फिलिङ्स त्यसपछि गएर कन्ट्याक्ट र कनेक्ट विथ रिसोर्स अथवा रेस्क्यु टिमसँग र अर्को चाहिँ प्रोफेसनल हेल्प मैले अब मेजरली चाहिँ मेरो कामको दौरानमा चाहिँ युथ अनि त्यसपछि गएर एजुकेसन राम्रो एजुकेसन ब्याकग्राउन्ड भएको सोसियो इकोनोमिक कन्डिसन राम्रो भएको तर युथ चाहिँ मेरो केसेसहरू जति पनि मैले केसेस सेयर गरेँ त्यो ब्याकग्राउन्डको हुनुहुन्थ्यो र पुलिसको डेटाले पनि हामीले अलिकति स्टडी हेऱ्यो भने चाहिँ पुलिसको डेटाले पनि नेपालमा 15 देखि 30 वर्षसम्मको उमेर समूहमा चाहिँ सबैभन्दा धेरै सुइसाइड केसेस हुन्छ भनेर देखाएको छ तर मैले यहाँ के जोड्न खोजिरहेको छु भने पुलिसको डेटामा अर्को पनि के इन्फर्मेसन देखाएको छ भने जस्तै मानव मोस्ट अफ द सुइसाइडल केसेस आर एट्रिब्युटेड टु लोवर सोसियो इकोनोमिक कन्डिसन त्यसपछि गएर मेबी एजुकेसन कम अनि त्यसपछि पोभर्टी भनेर देखाएको छ कि सो मेरो केसमा त अब थिएन मेरो जति पनि केसेस मैले हेर्छु उहाँहरू एलिट स्कुलमा पढेको सोसियो इकोनोमिक ब्याकग्राउन्ड राम्रो भएको साइको एजुकेसन राम्रोसँग उहाँहरूलाई थाहा भएको हुनुहुन्थ्यो सो यो किन भयो त भन्ने कुराले चाहिँ रिसर्च टपिक चाहिँ इन्करेज गर्यो सो एज अ अर्ली करियर रिसर्चर हामीले जस्तै मानव रिसर्च गर्ने ठाउँ नै छैन भनेर सोचिरहेका छौँ भने देयर आर सो मेनी हुन्छ नि टपिक्स जहाँ चाहिँ हामीले रिसर्च गर्न सक्छौँ यो सिम्पल केही टपिक्स छन् जुन मैले आजको सुइसाइड प्रिभेन्सनमा हामी काम गरिरहेका छौँ प्रेजेन्टेसन त्यसमै छ त्यही भएर यो टपिकहरू जस्तै सिम्पल सुइसाइड प्रिभेन्सन काम गरिरहेको छ कि छैन नेपालमा हटलाइन नम्बर भनेर भन्छौँ यसको इफेक्टिभनेस के छ भन्ने कुरा सँगसँगै हामीले यसमा यो अलिकति यो दुईटा मात्रै तिनटा मात्रै टपिक ल्याएँ जस्तै मिडिया रिपोर्टिङको इफेक्टिभनेस के छ देयर आर सो मेनी टपिक्स कति धेरै कुराहरू छन् तर सबैभन्दा ठुलो च्यालेन्ज एज अ अर्ली करियर रिसर्चर र प्र्याक्टिसनर र अर्ली करियर रिसर्चर जो बन्न खोजिरहेको छ अथवा जो अलिअलि काम गरिरहेको छ मैले देखेको चाहिँ रिगरस स्टडी डिजाइन र त्यो डिजाइनको इम्प्लिमेन्टेसन चाहिँ सबैभन्दा धेरै ठुलो च्यालेन्ज एज अर्ली करियर रिसर्चर मैले चाहिँ एक्सपिरियन्स गरेको छु र सँगसँगै अरू के ल्याकिङ छ त एज अ कति धेरै साथीहरू चाहिँ अर्ली करियर रिसर्चर स्टुडेन्ट्स मैले पार्टिसिपेन्टमा देखिरहेको छु सो आइ एम स्योर दे क्यान रिलेट मैले भनिरहेको कुरामा सो के चाहिँ ल्याकिङ छ त हामीसँग भन्दा त्यो एउटा पुस के त्यो एउटा मोटिभेसन कि सो हियर आर द टपिक्स दिज आर द टपिक्स द्याट यु आर इन्ट्रेस्टेड इन सो योमा चाहिँ हुन्छ नि वी क्यान हेल्प यु तपाईँहरूलाई यसरी हेल्प गर्न सक्छौँ भन्ने एउटा त्यो मोटिभेसन एउटा त्यो पुस सँगसँगै अर्को मैले एकदमै धेरै फिल गरेको कुरा चाहिँ प्र्याक्टिकल नलेज जस्तै म अमेजिङ रिसर्च टिमसँग यल युनिभर्सिटीको रिसर्च टिमसँग डाक्टर हागामेनको ल्याबमा अहिले काम गरिरहेको छु ग्रेजुएट अन्डर ग्रेजुएट स्टुडेन्ट्स दे आर अमेजिङ विथ लिटरेचर रिभ्यू अनि सबै कुरा कि म कहिले म पिएचडी गरिरहेको छु त्यसपछि आई नो अल द थ्योरिटिकल नलेज तर त्यो प्र्याक्टिकलिटी खोइ त सो त्यो राइट अप गर्ने त्यो नोज हाउस हुन्छ नि त्यो सानो सानो कुरा जसले चाहिँ रिसर्चमा इन्ट्रेस्ट भए तापनि त्यसलाई काम लाग्छ त्यो अलिकति नभएको हो कि त्यो हामीसँग ल्याकिङ छ कि भन्ने कुरा र अर्को इजिली अभाइलेबल डेटाबेस सो हामीसँग चाहिँ लिटरेचर सर्च गर्दाखेरि पनि हामीलाई एकदमै धेरै गाह्रो भएको मैले मेरो एक्सपिरियन्समा देखेँ सो त्यो चाहिँ ल्याकिङ एज अ एज अ अर्ली करियर रिसर्चरको एक्सपिरियन्सले चाहिँ मैले भन्न सक्छु। र अर्को कुरा चाहिँ यो जुन चाहिँ आई डोन्ट थिङ्क हामीले मिस आउट गर्नुपर्छ यो एउटा इस्यु चाहिँ, जस्तै मानौँ कन्फ्लिक्ट बिट्विन प्यासन र लिभलीहुड भनेर भन्छु कि। सो रिसर्चमा इन्ट्रेस्ट छ तर रिसर्चमा सेटलमेन्ट छ त, आर देयर एनी जब अपर्च्युनिटिज अथवा रिसर्चमा चाहिँ त्यो हुन्छ नि एउटा सेटल फिल गर्छौँ त हामी भन्ने कुरा पनि एकदमै धेरै ल्याकिङ छ एज अ अर्ली करियर रिसर्चर, एज अ प्र्याक्टिसनर हु वान्ट्स टु कम्बाइन रिसर्च साइकोलोजिकल रिसर्च भन्ने कुरामा चाहिँ मैले देखेको कुरा। र यो वान फ्रेन्ड हुन्छ नि वान फ्रेन्ड ब्रेनरको मैले इकोलोजिकल मोड्युललाई पनि अट्याच गर्दै यसमा अलिकति पनि कुरा गर्न चाहेँ। सो फर द च्यालेन्जेस के छन् त भनेर भन्दा अब हामी हुन्छ नि एकदमै माइक्रो लेभलमा गयो भने इन्डिभिजुअलको इन्ट्रेस्ट, नलेज, एटिट्युड अनि रिसर्च एज अ करियर भनेर नै, जस्तै मानौँ हामीले मास्टर्समा थिसिस, ब्याचलरमा सानो पेपर, द्याट्स इट, त्यति मात्र भए पुग्छ भन्ने कुरा, त्यो नोन्स र अननोन्सको ग्यापलाई चाहिँ वी क्यान डु समथिङ भन्ने कुरामा चाहिँ अलिकति त्यो इन्ट्रेस्ट अलिकति कम भएर आफैमा पनि सायद त्यसले गर्दाखेरि पनि एउटा द्याट इज इटसेल्फ अ च्यालेन्ज अर्ली करियर रिसर्चरलाई। र अलिकति हामी बाहिर जाँदाखेरि चाहिँ हायर एजुकेसन रिसर्चलाई कतिको तवज्जो त्यो भ्याल्यु दिएको छ त भन्ने कुरा पनि एकदमै धेरै एउटा च्यालेन्ज जस्तो लाग्छ मेरो एक्सपिरियन्समा जब मार्केट। किनभने एज अ रिसर्चर त्यो सेटलमेन्ट चाहिँ 2 वर्षको प्रोजेक्ट 5 वर्षको प्रोजेक्ट हुन्छ अनि त्यसपछि वाट नेक्स्ट भन्ने कुराले पनि एकदमै धेरै सताइरहेको हुन्छ एज अ रिसर्चर अथवा एस्पायरिङ रिसर्चरलाई। लाइकवाइज मेन्टरसिप अहिले बढिरहेको छ, आई डोन्ट से छँदै छैन भनेर, तर त्यो मेन्टरसिपको कुराहरू पनि हामीले धेरै नै एउटा च्यालेन्ज चाहिँ रहेको छ अर्ली करियर रिसर्चरलाई जस्तो लाग्छ। र अर्को हामीले हुन्छ नि ब्रडर हेर्दाखेरि चाहिँ रिसर्चको इम्पोर्टेन्स नै, सो नेपालमा रिसर्चको इम्पोर्टेन्स हाम्रो कल्चरल भ्यालिडेटेड टुल्स अथवा रिसर्च हाम्रै कन्टेक्स्टमा गरेको रिसर्चहरू एन्ड अल्सो नेसेसरी भन्ने कुराहरूको त्यसको त्यो इम्पोर्टेन्स पनि अलिकति कम देख्छु म। त्यो इट्सेल्फ अ च्यालेन्ज जस्तो लाग्छ। र रिसर्च कल्चर हाम्रो सोसाइटीमा करियर ओरिएन्टेसन, सो रिसर्च क्यान बी अ करियर भन्ने कुरा चाहिँ हामीलाई एटलिस्ट मैले चाहिँ हुन्छ नि हायर एजुकेसन पढ्दा पनि मैले चाहिँ रियलाइज गरिनँ। सो त्यो पनि एउटा मैले च्यालेन्ज देख्छु। अर्को च्यालेन्ज भनेको फन्डिङ, जुन हामी सबैजना रिलेट गर्छौँ। वी हेभ आइडियाज, अघि कति कुरा गऱ्यौँ, देयर आर सो मेनी टपिक्स वी क्यान एक्सप्लोर अन, होइन, कति धेरै इन्ट्रेस्टिङ टपिक्सहरू छ जसमा हामी गर्न चाहन्छौँ, जसलाई चाहिँ रिसर्च निडेड छ तर बिकज अफ फन्डिङ। र अर्को चाहिँ म यो पोलिटिक्स अफ पब्लिकेसन पनि भनेर भन्छु, इट्स अ हेभी वर्ड, पोलिटिक्स अफ पब्लिकेसन, तर बिकज अफ ल्याङ्ग्वेज बेरियर, वी कम फ्रम नेपाली ल्याङ्ग्वेज, हामीले त्यही नै पढिरहेका हुन्छौँ, बिकज अफ द्याट पनि पब्लिकेसनमा हामीलाई गाह्रो हुने। सँगसँगै नेपाली रिसर्चर अर्ली करियर रिसर्चर चाहिँ मैले त्यो हुन्छ नि जस्तै मानौँ यो प्रेडिटरी जर्नलबाट चाहिँ एकदमै धेरै इन्फ्लुएन्स्ड भएको पनि देखिरहेको छु, अथवा हामीलाई थाहै छैन कुन चाहिँ आइएसबिएन भएको कुन चाहिँ होइन भन्ने। सो त्यस्तो कारणले गर्दाखेरि पनि त्यो पनि एउटा च्यालेन्ज एज अ अर्ली करियर रिसर्चरलाई छ भन्ने चाहिँ मलाई लाग्छ। अब यो च्यालेन्जसँग अर्को इस्युज के एज अ अर्ली करियर रिसर्चरले फेस गर्न सक्छ अथवा गरिरहेको छ, मेरो एक्सपिरियन्सले, मेरो स्टुडेन्टसँगको एक्सपिरियन्सले चाहिँ मैले भन्दाखेरि यो इम्पोस्टर सिन्ड्रोम, जस्तै कहिले कहिले चाहिँ वी एक्चुअली फिल कि आई डोन्ट नो एनिथिङ, अथवा के भइरहेछ, अब म पिएचडी त गरिरहेको छु अथवा मास्टर्स त सकेँ, अथवा बिकज यो कुराहरू चाहिँ छ मसँग नलेज थ्योरिटिकल, तर मैले गर्न सकिरहेको छैन भन्ने त्यो कुराले पनि एकदमै धेरै असर पारिरहेको। कन्फ्युजन अबाउट ओन करियर, जस्तै मानौँ अघि मैले सेटलमेन्टको कुरा जस्तै हुन्छ नि, इज देयर एनी सेटल्ड के करियर आउट, क्यान आई फाइन्ड अ सेटल्ड करियर आउट अफ रिसर्च भन्ने कुरा, अथवा म केमा जान्छु त, कुन चाहिँ मेरो टपिक हो भनेर हुन्छ नि त्यो कन्फ्युजन जहिले पनि। र साइकोलोजिकल सपोर्ट, जस्तै मानौँ हामीले त अब एक्टिभ लिसनिङ गरौँला, भ्यालिडेसन गरौँला, हामीलाई चाहिँ कसले गर्ने, सो त्यो कुराहरूले अथवा कहाँ रिच आउट गर्न सक्छौँ भन्ने कुरा, त्यो पर्सनल पनि र कहिले कहिले चाहिँ सपोर्ट ग्रुपमा पनि, जस्तै मेबी च्यालेन्जेस सेयर गर्ने कोही, अथवा मेबी हाम्रो सर्टेन नेटवर्क हामीले बनाउन सकियो भने पनि त्यो इस्युज चाहिँ धेरै घट्थ्यो होला, अथवा यो सपोर्ट नेटवर्क अफ रिसर्चर्सले गर्दाखेरि पनि एउटा इस्यु चाहिँ एकदमै धेरै गाह्रो हुन्छ भन्ने कुरा। र यो कुरा चाहिँ छुटाउनै नहुने कुरा चाहिँ मैले यो प्रब्लम इन वर्क लाइफ ब्यालेन्स भनेर पनि भने, एटलिस्ट स्पेसिफिकल्ली फिमेल रिसर्चरलाई चाहिँ अझै धेरै मैले त्यो कुरा चाहिँ अट्याच अथवा त्यो कुरा चाहिँ मैले जोड्न सक्छु के। जस्तै मानौँ जस्तै वी निड टु ब्यालेन्स अब एकाडेमिया पनि, रिसर्च पनि, त्यसपछि फ्यामिली पनि, त्यसपछि त्यसले गर्दाखेरि पनि द्याट क्यान बी इस्यु इन इटसेल्फ। त्यही भएर अघि एस्लीले भन्नुभएको थियो वी गिभ मेन्टल हेल्थ ब्रेक्स फर आवर रिसर्च टिम भनेर। सो त्यो कुराहरू चाहिँ नेसेसरी छ, किनभने यस्तो इस्यु चाहिँ हुनसक्छ भन्ने कुरा पनि एकदमै धेरै एक्सपिरियन्सले देखाएको अथवा हामीले सुनिरहेको कुराहरू चाहिँ मैले जोड्न चाहे र अन्तिममा सो कसरी इन्हान्स गर्न सकिन्छ त पर्सनल र प्रोफेसनल वेलबिङ अफ अर्ली करियर रिसर्चर भनेर पनि यो स्लाइड जोड्दै चाहिँ सबैभन्दा इम्पोर्टेन्ट कुरा चाहिँ यो सो आर वी टकिङ अबाउट हाम्रो इस्युज हामी चाहिँ मोस्ट अफ द टाइम जस्तै मानौँ कहिले कहिले त्यसले गर्दा पनि ओभरबर्डन भएको त्यसले गर्दा पनि अप्ठ्यारो धेरै भएको त्यही भएर पर्सनल वेलबिङ पनि एकदमै नेसेसरी छ फर द्याट तपाईँले लिइराख्नु भएको छ काउन्सिलिङ अथवा सपोर्ट भन्ने कुरा अनि त्यसपछि गएर प्लिज टेक मेन्टल हेल्थ ब्रेक्स अथवा तपाईँलाई के मनपर्छ यु क्यान डु द्याट सो द्याट इट्स नट जस्ट अबाउट मेबी तपाईँको काम मात्र होइन नि त सो कहिले कहिले चाहिँ यसरी इफ यु क्यान फाइन्ड टाइम आउट इन बिट्विन त्यसले पनि धेरै सजिलो गराउँछ फिजिकल हेल्थ त्यत्तिकै इम्पोर्टेन्ट छ फिजिकल हेल्थ पनि जत्तिकै तपाईँले आफ्नो रिसर्चमा ध्यान दिनुहुन्छ करियरमा ध्यान दिनुहुन्छ यसरी पर्सनल वेलबिङमा पनि ध्यान दिनुभयो भने चाहिँ इट इज गोइङ टु इन्हान्स र हुन्छ नि कन्सिक्वेन्स चाहिँ हाम्रो रिसर्च करियर अथवा हाम्रो एकाडेमिक जर्नीलाई पनि सपोर्ट हुन्छ र अर्को चाहिँ प्रोफेसनल वेलबिङ कसरी इन्हान्स गर्न सकिन्छ भन्दा चाहिँ सुपरभाइजर सपोर्ट हामीलाई रिसर्चले देखाएको छ हुन्छ नि इफिसियन्सी धेरै बढेको यदि हामी राम्रो सुपरभाइजर अथवा सुपरभाइज राम्रोसँग भइरहेको छौँ भने र सँगसँगै चाहिँ मेन्टल हेल्थ ब्रेक्स भेरी नेसेसरी प्रोफेसनल वेलबिङमा यो एक्टिभ लिस्निङ र भ्यालिडेसनको यो टिममा अथवा मेबी फर द्याट रिसर्च जस्तै मानव कहिले कहिले च्यालेन्ज हुन्छ कहिले कहिले अप्ठ्यारो हुन्छ फर त्यो बेलामा पनि वी क्यान यो हामीले एउटा सपोर्ट नेटवर्क खडा गरेर हामीले गराउन सकियो भने देन हाम्रो वर्क लाइफ ब्यालेन्स मेन्टेन गर्नको लागि चाहिँ सो आर यु एक्चुअली इन्ट्रेस्टेड कि तपाईँ हुन्छ नि लहलैमा रिसर्च गर्न खोजिराख्नु भएको छ कि अथवा तपाईँले ब्यालेन्स गर्न सकिराख्नु भएको छ कि छैन सो यस्तो धेरै कुराहरू हेऱ्यो भने पनि इन्हान्स चाहिँ हुन्छ एज अर्ली करियर रिसर्च हामीले आफ्नो वेलबिङ चाहिँ इन्हान्स गर्न सक्छौँ भन्ने कुरा चाहिँ मैले जोड्न चाहेँ र छोड्नै नहुने कुरा सिन्स हामीले सुइसाइड प्रिभेन्सन हुन्छ नि मन्थ सेलिब्रेट गरिरहेका छौँ सो सुइसाइड प्रिभेन्सन मन्थ सेलिब्रेट गरिराख्दाखेरि चाहिँ सो इट्स नट फर अरूलाई पनि होइन हामीलाई पनि सो वाइ डोन्ट वी हेभ दिस काइन्ड अफ हटलाइन नम्बर हाम्रो फोनमा इजिली अभाइलेबल हुने तरिकाले हामीले कसैलाई सपोर्ट गर्नको लागि अथवा मेबी कहिले कहिले आफैलाई पनि इमर्जेन्सी पर्दाखेरि यो पनि राख्न सक्छौँ भनेर यो चाहिँ हामीले इन्ट्रोड्युस गर्न चाह्यौँ सो हामीसँग हेल्पलाइन र हटलाइन नम्बर्स छन् र लाइकवाइज सुइसाइड प्रिभेन्सन मन्थ हामीले सेलिब्रेट गरिरहेका छौँ देयर आर सर्टेन रिसर्चेस जुन भइरहेको छ त्यसले देखाइरहेको छ कि इट इज एक्चुअली नेसेसरी टु टक अबाउट सुइसाइड टु टक अबाउट मेन्टल हेल्थ भनेर सो लेट्स स्टार्ट डुइङ द्याट अब यसमा चाहिँ इट्स नट अब सबैजनाकोमा चाहिँ आफ्नो एज अर्ली करियर रिसर्चर्स पनि तपाईँहरू एज अर्ली करियर प्र्याक्टिसनर्स पनि हामी सबैजनाले हाम्रो मेन्टल वेलबिङको बारेमा चाहिँ कुरा गर्नै पर्छ भन्दै सो त्यति भन्दै आई वुड लाइक टु थ्याङ्क टिपिओ र जर्ज वासिङटन युनिभर्सिटीलाई फर दिस अपर्च्युनिटी एन्ड लुकिङ फरवर्ड टु फिडब्याक एन्ड क्वेसन्स थ्याङ्क यू सो मच
Thank you so much, Kripa. Thank you so much, Ashley. This was such a wholesome presentation, such a wholesome webinar, and I can't imagine anyone for whom this was not relevant. We already have a bunch of questions. Super quickly, everybody, the feedback form is in the chat box. My feedback form chat box ma halisakeko chu. Ma questions haru consolidate garday garchu tabasamba Maniji I can see tapaiko hat ubeko cha. Please apply unmute garera questions sodinu hola.
Thank you, Ritika ji. So first of all, namaste Ashley. Kripa, thank you for such a wonderful presentation, and it was really helpful for early career researchers. So here is my first question. So how can we integrate the health and agriculture system for suicide prevention and integrated research on it? So as we know, suicide by intentional injection of pesticides is very much common in low and middle income countries and agricultural countries like Nepal and most of the Asian countries. And as far as part of my literature review, I have not found many more research on health and agricultural integration for suicide prevention, and this may be the area where the early researcher and early careers like us can focus on it. So here I just want to be clear that, so what may be the ideas for integrating health system and agricultural system for combined research work in suicide prevention in low and middle income countries and agricultural based countries like Nepal?
So is integrating suicide prevention with the health system and what other system?
So health system and then after agriculture system So because as we know, suicide by ingestion of pesticides is much more common in low and middle income countries and agriculture-based countries like Nepal. So I have not found many more research that has been conducted on health and agriculture intervention for suicide prevention.
So I'll respond to, I think, how I'm understanding the question. I can't tell if it's economic system or educational system. But so for means reduction, there are many opportunities at the national level to prevent suicide. So Sri Lanka has done, and even places in India have done really remarkable interventions where they actually change what pesticides are legally available and sold. And so just at a national level, you might not be able to buy a pesticide that is lethal. So that has dramatically reduced suicide deaths. It has not dramatically reduced suicide attempts. Another intervention has been pesticide safes. So where communities like VDCs will come together to create a safe system where all the pesticides are stored in an external location that is locked and only accessible to certain people at certain times of the day. So pesticides are no longer stored in the home. So those are some interventions for means restriction. For health system integration, there are things like I talked about, like universal screening. And the MHGAP training is preparing clinicians to ask questions of suicide and then be able to respond with small things that they can do that can help bridge someone and get them better connections to care. So these safety planning interventions can be actually quite effective. So those are some things. I don't know if Kripa has anything to add.
Likewise, Ashley, हामीले एउटा मनिजी मैले नेपालीमा रेस्पोन्ड गरेँ हामीले लिटरेचर रिभ्यू पनि गरिरहेका छौँ लाइक एस्ली सेड जस्तै मानव पेस्टिसाइडको कन्ट्रोल र यसलाई इलिगल गराएर नै हामीले सुसाइड प्रिभेन्सन गर्न सक्छौँ भन्ने कुरा पनि कति देखाइरहेको छ तर एट द सेम टाइम चाहिँ द्याट इज नट द एन्ड रिजल्ट त्यसमा चाहिँ ब्रिफ जस्तै मानव हामीले ब्रिफ कन्ट्याक्ट अथवा फलोअप अथवा रेगुलर इन्टरभेन्सन ब्रिफ इन्टरभेन्सन किनभने लङ टर्म इन्टरभेन्सन गरेको र पनि त्योभन्दा पनि इफेक्टिभनेस चाहिँ ब्रिफ इन्टरभेन्सन गरेको देखिएको छ त्यही भएर like Ashley said, brief intervention त्यो बेलामा त्यसको लागि चाहिँ हामीले त्यो इन्टरभेन्सन मोडालिटी ल्यायो भने चाहिँ we can prevent.
Thank you so much.
Thank you guys. Simone ji, I can see तपाईको हात उठेको छ तर can you give me just 2 minutes? Just wrap up the questions that are on the chat box. One thing, people, we have around roughly 7-8 minutes after which we will have to wrap up. Please do not be worried if your question is not addressed. तपाईको question यदि address भएन भने please worry नहुनु होला. You can just write to us. We will be in touch and we will make sure that Kripa and Ashley receive your questions. And this is like a longer process. It's not just that this webinar is over and we're done. This is a continuous learning environment. So please forgive us if there isn't enough time to come to all the questions. Okay, super quickly, there is a question from Christina. This is for you, Ashley. How did you decide which activities such as group counseling sessions to provide for the lab? I hope other organizations and actors in global health follow suit ASAP. This is so needed. Do you have advice for those who want to advocate for these types of activities within our teams, such as how to carve this priority out in budgets?
I think that's a question to funders that researchers need to push for. You know, for now, we create the budget for it. To be frank, if I don't have the budget for it in the grant that is funding the study, it comes out of my discretionary funds from my university. So I choose to use those funds for those reasons and for the support and training of my staff. Our department has done some work also to make sure that we can support folks. So there's just a lot of advocacy to the institutions that we're working with. You know, I hope this op-ed piece is published in to make a call for grant funding agencies to have funds that are set aside or additional funds that can support research team efforts. I mean, for group sessions, I mean, really just our regular team debriefs became those sorts of opportunities for people to share what was difficult for them, to talk about what they learned in the field that day, and to have some affirmation and validation of their thoughts and feelings. And so we just systematized that and created a separate space for it. So everyone knew that this was the time and space that we would spend together as a team doing that. You know, frankly, working with Seema, who's also on the call, we learned a lot together about what was really hard about doing that work and kind of what we needed individually. And so I think just experience and kind of being responsive to our teams.
Thanks, Ashley. Another question. This is probably more for Kripa. When we are working with a client and she shares their suicidal ideation but doesn't want anybody else to know their thoughts, as a counselor, we are supposed to inform someone whom our client trusts. But what if the client strongly insists on not telling anyone? How can we convince them?
That's a very relevant and that's a very good question as well. Most of the time people do not want to share what they are going through. We can start with basic skills like creating a safe space where they can share. Why people do not share? Because they feel judged, or they feel certain maybe effectiveness because of mental issue. So if you can start with creating certain spaces, certain safe space for our clients or for somebody we are working with, and tell that there is support. So you can start with active listening. You can start with creating a safe space where there is no judgment. You can start with asking questions, right questions in the right time, and especially not necessary. Sometimes you don't need to you don't need to say time and again you can just let them know you are available whenever that person is wanting to talk. So this that can open the conversation and make that individual feel more understood, and then more they can start trusting the people around more, and then they can open up, or they can be convinced they need help on it.
And from a research perspective, I'll just speak to in our informed consent procedures, which is not a one-time event, right? So we are very clear about when they share something that we are mandated. It is our policy that we have to get them care and support to keep them safe, because their safety is our priority. And so as soon as they enter their study, we are responsible for that safety. And so we are very clear about what they share and what will happen if they share it. And then that, again, we don't only do that at the beginning of the project and then never do it again. We do it when we start talking to them. We do it when we finish talking to them, and then at every follow-up encounter. And so I think a lot of us think about this consent process as like, okay, you got the signature, now we're done. But we have steps within our protocols to continue that ongoing consent throughout interviews, throughout engagement, during and after.
Thank you, guys. Thank you, Ashley, Kripa. Simone G, please, could you put your question, unmute yourself? I would really request you to please keep it short, though, because we don't have a lot of time.
All right, thank you. Thank you so much, both of you, for the lovely presentation. I just wanted to ask, most of the advocacy that we've seen around suicide prevention is quite apolitical in nature. And I wouldn't say that all the suicide cases are political or like have an underlying social cause, but I don't really see a lot of social or political activism towards suicide prevention. So is there anything in your research, like any dimensions that can overlook this scenario, like especially in context of Nepal or anything like that can be done?
So is it like what kinds of advocacy can our research contribute to?
Yeah, like it just seems a little apolitical to me based on your presentation. So it doesn't seem like there's a lot of political or social constructs involved there to make a bigger impact, I would say, if that makes sense.
I mean, I think from policy perspectives, it's what is the universal training that clinicians are receiving? So are they receiving training in suicide prevention? Do they feel comfortable and confident asking those questions? Can we systematize that in the training practices? In the health system, how are we systematizing the documentation of suicide? So the Emerald study, Nabaraj Adhikari has done a lot of work to figure out within the health system how to systematize that documentation for suicide attempts. You know, I think other policies that could be advocated for, that this is why we engage stakeholders, this is why we engage the police, this is why we engage the educational system when we do any of these interventions, is that, you know, there can be funds for, you know, like gatekeeper training. So training teachers, training police officers in responding. And I know TPO Nepal has done a lot of work in that. So I'm not sure if I'm directly answering your question, but the way that we incorporate it into our research in particular is by engaging these stakeholders and having conversations with them about how sort of we can create these wraparound systems of care.
All right, thank you.
Thank you so much. I love the fact that everybody has been so invested in this webinar. Thank you everybody for so many great questions. I apologize that we cannot get to all of these now, but the offer stands. Please write to us with whatever outstanding questions you have, and we will make sure that Ashley and Kripa get the questions. We will have to wrap up the webinar soon. So Drishti, can I please ask you to wrap up the webinar for all of us?
Sure. So thank you so much, Ashley and Kripa, first of all, for giving such wonderful presentation. And thank you to all the participants here today and asking all these wonderful questions. We really regret that we couldn't address all of the questions. But as Ritika mentioned, please feel free to email us. And also, I believe both Ashley and Kripa are in Twitter, so you guys can follow them as well and ask these questions, or you can follow us in Twitter in our mental health research, Nepal Mental Health Research Twitter account, and also interact with us over there. So thank you to both of our speakers, first of all, for giving us a great presentation and telling us about your personal trajectory, which I think is very useful and helpful for us early career researchers to inspire us on our own career trajectory as well. Thank you again for raising issues around participant safety, especially in research related to suicide. And as Ashley mentioned, signposting and safeguarding the participants is very important, especially, and not just only in suicide-related research, but in mental health research and all research in general. And most importantly, thank you both for highlighting the need for mental health care for the researchers, which normally doesn't, we don't hear about it often in the research. So in your research, you've safeguarded funding for that, and that has been very inspiring personally to me. And also thank you, Kripa, especially for raising a lot of points for early career researchers, especially around challenges that early career researchers face, such as challenges around motivation, resources, mentoring issues. And I just want to highlight that this webinar series and the Nepal Mental Health Research Network, we do want to address all of these challenges, and which is why we're organizing all of this. So hopefully with this webinar series, and also with we're also planning other activities under this network, and with that we really hope to address all these challenges that early career researchers face. So please do look forward to that, and please do keep on interacting with us. Thank you again so much to the speakers and to all the participants who joined in today. Thank you. Ritika, over to you.
Sorry. Thank you so much, Drishti. Just to mention to everybody, Ashley has put in her email address on the chat box. I have also put in the MHRN email address in the chat box, and the feedback forms are also in the chat box. Everybody, please take some time to help us make ourselves better for the betterment of everybody who is involved in this process. Thank you, everyone. Many, many thanks, Kripa and Ashley, and many, many thank you, Drishti. Many, many thank you to all the participants. Drishti has also put in the suicide hotline in the chat. So please try and put down all the information that is over here. And with this, we are ending the webinar. Thank you, everyone, for your patience.
Thank you.
Thank you, Sabizana. Namaste.